If you have been on a plane, you may know that there are many, many sensors keeping track of all the different functional aspects of the plane as it journeys through the air. And it's only with the help of these sensors that the pilots, that the ground crew can ensure that this plane safely lands at its destination. And our hope is that for you and I in the community, for patients in a hospital, that we can leverage the unprecedented opportunities which are now provided by wearable sensors to track people's health continuously. As we've seen today, wearable sensors now come in a variety of different forms, shapes and sizes and functionalities. Here is a small selection of sensors suitable for use, some in a hospital, some more in a community setting. And for the purposes of this talk, I'll be defining a wearable sensor as a body-worn device which senses the person wearing it. As was mentioned, I work at King's College London, and I work jointly with clinicians at Guy's and St Thomas's NHS Foundation Trust. And together, we hope to develop signal processing techniques which can be used to extract parameters from the signals provided by wearable sensors, and then that those parameters could be used to inform clinical decision making. So in today's talk, I'll give an outline of the engineering techniques which we use. I'll show some case studies of the potential clinical utility of wearable sensors, and then I'll finish with some of the challenges and opportunities facing us. So firstly, just to overview the signals which wearable sensors can capture. The first I'll mention is the photoplethysmogram, or PPG for short. And this is a measure of the volume of arterial blood. It's obtained by shining a light onto a tissue, such as the skin underneath a smartwatch, and then measuring the amount of light either reflected back from the skin or transmitted through the skin, such as in this example on a finger. Here is this signal, and just to explain its origins, some of it is due to the pulsations in arterial blood which occur with each heartbeat, and then other components are more stationary, such as the attenuation of light due to arterial, venous blood and other tissues. Another signal which we commonly use in the hospital is the electrocardiogram, or ECG, a measure of the heart's electrical activity, which can now be obtained using patch-style sensors mounted on the chest. We've heard lots about the accelerometry signal already today, and there are various other signals which are found slightly less commonly in wearable sensors, such as measuring the pulse wave due to changes in blood pressure, breathing signals such as the impedance pneumography signal, a gyroscope signal, and the seismocardiogram, a measure of vibrations due to the heart. And each of these signals provides opportunity to estimate a series of clinical parameters which could be used for decision making, along with other parameters. This isn't an exhaustive list, that can be obtained from other sensors as well. So I'm now just going to take us through a few of the signal processing techniques that we use, starting with one of the most fundamental, estimating heart rate. So just to demonstrate, here is a 10-second portion of ECG signal, and the aim is to determine the heart rate, the number of beats per minute from this signal. Now this is relatively straightforward in this example. Each sharp spike represents an individual heartbeat, and so by simply drawing a threshold through the signal, one can identify those peaks which fall above the threshold and then calculate the heart rate using the number of beats within that 10-second window. However, there are slightly more complex examples. So for instance, this is an example of a patient with an arrhythmia, and here the amplitude of the QRS spikes changes during the recording. So the use of a fixed threshold wasn't particularly helpful in this example, and instead one could take a slightly more complex approach of using an adaptive threshold to try and identify more of the heartbeats. But even this fails in the middle of the signal. Here is another common problem faced when using wearable sensors, that of the corruption of signals due to motion artifact. In the first 5 seconds of this signal, there is motion artifact, and some of the heartbeats haven't been identified by using an adaptive threshold. So here we could make the algorithm even more complex by instead analyzing the first derivative of the signal, which tells us about the slope of the signal and therefore amplifies the effect of these sharp spikes. And by applying the threshold to the first derivative, we can now pick up most of the heartbeats successfully. This process can also be repeated for the PPG signal, found in smartwatches, here being successful even in the presence of an arrhythmia. I've been fortunate to work on trying to estimate respiratory rate using wearable sensors. And here the challenge is that most of the sensors which one would routinely use to monitor breathing are not suitable for use with wearable sensors. So in these examples, these are probably too cumbersome for most situations with wearable sensors. So the alternative approach which one could take would be to try to estimate respiratory rate, the number of times you breathe in a minute, from the ECG or the PPG signal. And the hope is that if one takes the PPG signal from a sensor, then when comparing to a reference respiratory signal, one could extract a similar respiratory signal from which one could estimate the respiratory rate. And indeed, in this case, the respiratory rates given, 18 and 17 breaths per minute, are similar between the two. An algorithm to perform this task might take 3 stages, starting with the extraction of respiratory signals, which is based on the observation that the PPG signals on the left and ECG on the right are modulated by respiration in 3 different ways. So working down from no modulation at the top, they're modulated by baseline wonder, amplitude modulation, and frequency modulation. And it's by extracting one or more of these subtle modulations that one can attempt to estimate respiratory rate. Taking the PPG as an example, one would identify the individual heartbeats in the PPG and then the peaks and troughs for each heartbeat. One could then take measurements, firstly of the baseline, the average between a peak and a trough, and then of the amplitude and instantaneous frequency, and then use these measurements to provide respiratory signals. And here the hope is that each peak in a respiratory signal indicates 1 breath. So the next task, once we have a signal, is to estimate respiratory rate from it. And there are 2 broad approaches to doing this. The first is similar to that used for estimating heart rate, where one identifies individual peaks in the signal, here giving a respiratory rate of 17 breaths per minute. An alternative is to look at the frequencies which make up the signal. And on the right is shown a plot of the contributions of frequencies to the signal, and it's dominated by a frequency of 18 breaths per minute, a similar result. Incidentally, that's similar to the approach one could use for obtaining a step count from an accelerometry signal. So once one has an estimate, one might want to improve the performance even further, and one can use Fusion to do this. So you may have 3 different estimates shown in red, derived from the 3 different modulations. Take the average, or the Fusion, shown in blue, which in this example gives an answer which is closer to the reference respiratory rate. An alternative is to take a single estimate over time, shown by the green dots, and to smooth it, take a moving average over time, giving the black fused line, which is in closer agreement with the reference than the individuals. Even so, having performed these tasks to try and improve the reliability of parameters, there are still cases of signals which we simply cannot obtain these parameters reliably from. And so we've been working on signal quality indices, which attempt to distinguish between high and low quality periods of signal so that we can eliminate low quality periods of signal from an analysis. So an approach we could use to do this, again, starts with identifying individual beats. Secondly, to calculate the instantaneous heart rate from those beats, see if it looks plausible by comparing it to a series of rules, and then to use template matching, so taking the individual beats shown in grey and comparing them to the average overall beat shape, and seeing if the individual beats have a similar shape to the average or not. This can also be applied to the ECG, shown in the top row, allowing us to distinguish between high quality periods, shown on the left, where the individual beats have a similar shape to the overall average, and low quality periods, where the individual beats diverge quite dramatically from the average shape. We've assessed the performance of this technique in the hospital environment, and we found that we thought it performed reasonably, giving high sensitivity and specificity when compared to manually annotated data. We also think it's beneficial to apply this to data acquired by wearable sensors. So as an example, here is at the top, pulse rates obtained from the PPG, and then the arterial oxygen saturation also obtained from a PPG sensor. The red dots show the original data, and then overlaid in blue are those data which were derived from periods of high signal quality. And you'll notice that in this example, many of the outliers have been discarded. They were derived from low quality data. Moving on to some case studies of the potential clinical utility of wearable sensors. This first one concerns estimating respiratory rate continuously. Respiratory rate is a key marker of acute deteriorations in hospital. So an elevated respiratory rate is often an antecedent of a cardiac arrest. Here are respiratory rates estimated every minute during a 3-day stay on a hospital ward. And you'll notice that many of these lie outside of the normal range. And so the first step I took was to instead find the average respiratory rate every 15 minutes, which cuts down the amount of noise despite those techniques having been used earlier in the workflow. And then comparing these to manual measurements, we see there is reasonable agreement, but this provides additional information. So for instance, in the early part of the recording, the wearable sensor data shows low respiratory rates of approximately 12 breaths per minute, which weren't picked up on by the manual measurements. Then to apply this in practice, so here are similar respiratory rates, this time derived from a signal of a patient who suffered from a cardiac arrest at the end of this day's recording. The manual measurements are shown in red as a comparator. And the measurements from the wearable sensor were by and large elevated, well beyond the normal range, and would trigger an alert, a clinical response. So in this scenario, it may have been helpful to monitor respiratory rates continuously to provide a predictive marker of a cardiac arrest and potentially intervene earlier. For a third case study, here I have tried to calculate a continuous early warning score. This is a score that hospital clinicians will use to assess the likelihood of a deterioration in the next few hours from a series of physiological measurements. Some of the measurements are shown on the 2nd to 4th rows, the respiratory rate, the heart rate, and the oxygen saturation. They're shown from the wearable sensor, the small dots, and then the manual measurements, the large dots. And I've aggregated these together to calculate this score, where higher values indicate a greater likelihood of deterioration. And here, these values were relatively low, suggesting this patient wouldn't deteriorate, and indeed they were discharged from hospital at the end of these 3 days. In contrast, the scores derived from this patient were substantially higher, and these would have generated alerts for the vast majority of these 2 and a bit days for which they were monitored. And indeed, this patient was taken to surgery and then readmitted to critical care not long after. So we wanted to assess, would it be reasonable to calculate an early warning score continuously using wearable sensors? To do this, we obtained data from 184 patients who were recovering from cardiac surgery, they each wore a wearable sensor for approximately 4 days. And we compared the performance of the early warning scores for predicting on the left serious deteriorations and on the right more minor deteriorations. And we found that the performance in red of the wearable sensor data was similar to the performance of the intermittent data, suggesting that yes, perhaps the parameters derived from the wearable sensor data were accurate enough for this purpose, but crucially, it updated the likelihood of deterioration continuously. Moving towards the community, one emerging application is the identification of atrial fibrillation, an arrhythmia which is associated with an increased risk of stroke. Here I've shown how one might do it using the ECG or the PPG on the first and second rows as an input signal. Firstly, identifying the individual heartbeats, and then on the third row, calculating the interbeat intervals from those heartbeats. And the first thing to notice is that the example on the left-hand side, which is this patient with atrial fibrillation, exhibits higher variability in the interbeat intervals than on the right-hand side, which is this patient when they were in a normal rhythm. And that's to be expected. It's a marker of atrial fibrillation that there is greater irregularity in the beat-to-beat timings. Secondly, despite my best efforts, this beat detector has failed here, which is why there is an outlier, just to highlight a potential pitfall. Finally, the use of wearable sensors in the community provides opportunity to assess people's response to exercise. It's well documented in the literature that the rate at which the heart rate returns to normal following exercise is an indicator of cardiovascular health. And it's been suggested recently that not only that may be helpful, but the actual shape of the pulse wave may also be indicative. So, to finish, some challenges and opportunities. Challenges, firstly, evaluating these sensors. Just a simple example, this person wanted to assess the relative performance of their smartphone and a pedometer for counting their steps. So they walked to the shops and back, and they counted as a reference the number of steps they took. And they didn't do too badly. I thought this was quite impressive. But there are some limitations to this evaluation, which apply more widely. Firstly, they only walked to the shops and back, so we don't know what would have happened had they bounced on a trampoline, had they gone to the swings instead, had they bought their newspaper, which the shop had run out of. And secondly, they said afterwards, I'm not sure if that manual reference was actually correct or not. So we don't know necessarily if our reference is entirely accurate. How do we attempt to get around this? Well, the studies we do are either in the laboratory, where we have the benefits of often knowing the reference accurately, being able to control the conditions, obtain high quality signals, whereas in the clinic, we have signals acquired in a wide range of activities. And it's by combining studies from these two scenarios that we're able to perform in-depth evaluations. We're in the process of collating benchmark datasets, which we hope can be used by the community to test their algorithms, such as this one, with signals alongside reference respiratory signals, and then using computational modeling to simulate the shape of the pulse wave, both for young subjects at different sites around the body, and then for middle-aged and elderly subjects as well. There are other challenges. There are links throughout the presentation. Finally, opportunities. The arterial pulse wave, which is measured by wearable sensors, is influenced by both the heart and the cardiovascular system. So potentially one could extract a lot more information than just the heart rate from it. And we are working with techniques to identify individual points on both the pulse wave at the top and then its derivatives on the next few rows, and then to take measurements from it, which we think may be indicative of parameters such as the duration of systole. Secondly, one could develop techniques to monitor health conditions rather than simply individual parameters. And here we've done some in silico work with monitoring mental stress, which is of crucial importance in the workplace and for monitoring productivity. Finally, we could extract new parameters. So parameters of arterial stiffness, indicative of cardiovascular health. That's what we're currently working on. And then secondly, we could use the existing parameters instead to monitor respiratory health in the community. In this case, predicting exacerbations in chronic obstructive pulmonary disease from 3 routine parameters acquired from a wearable sensor. So to conclude, in my experience, I believe there is much need for collaboration between engineers and clinicians. There's been a lot of research into engineering techniques, but now it's only with that collaboration that we can continue to research clinical applications. There are several challenges ahead which we could overcome in order to provide greater and greater patient benefit. With that, I would like to thank my colleagues, our funders. I would like to point you towards the references for the work I've cited and also the data that I've used. And also, I'll put these slides online in not too long, and do please feel free to get in touch. Thank you very much.
Thank you so much for that, and thank you for showing us the different types of information you can extract from physiological signals as opposed to just biophysical signals like you can see. So does anyone have any questions?
Thank you. That was a lovely talk, and you really walked us. I like to walk through the different, starting from very simple, etc. So I also am involved in similar work, and the signals that I tend to deal with are often of a much lesser quality than the ones that you've shown in this presentation. And so I was wondering about, maybe it's in your publications, but how robust your algorithms are. You mentioned the lab settings where you have really nice ECG, PPG, etc. But as you no doubt know, if you move to the wearable world, your PPG, especially at the wrist, and your ECG also will look very different to the ones. And so I was wondering about the robustness and whether you also investigate that for wearables.
So what I presented today was primarily conducted in the hospital setting, where we have the luxury of being able to discard low quality data. So we did discard low quality data. There are other techniques available to try and make use of low quality data to improve its quality, which we could discuss. I showed some of the pitfalls with atrial fibrillation with the outliers in the raw respiratory rate estimates. So I don't claim that these techniques are perfect. I also showed the necessity of taking an average of respiratory rates over a minute and then averaging that over 15 minutes to obtain a vaguely reliable estimate. So in the real world environment, yes, they're noisy. Yes, the parameters are less reliable, but nonetheless, I think I've demonstrated here some potential clinical application despite that very real difficulty.
Great, any more questions? Right, so let's thank Peter one more time.